Assalamualaikum, Prof. Saleh.
Baik, Prof.
Testing line clear ke untuk saya? Line saya clear ke?
Katanya apa jelas. Suara berenung. Kenapa ni Rasman? Sekejap ya, kita settlekan suara.
Dia bunyi dengung.
Ada yang boleh dengar?
Saya jelas tapi ada echo.
Ada echo ya? Okey.
Tapi suara saya clear?
Okey, suara. Is it better now?
Yes.
Okay, thanks. Kita dah start Rosman. Nak kita play your slide
Just a quick review, very short slide. I think tapi saya I would do more of a discussion and perbincangan lah rather than ni.
Pasal saya kena dengar suara, saya tak dengar suara. Macam mana?
Saya boleh dengar suara Prof. Saleh.
Boleh dengar saya punya suara dengar
Ya.
Cuma kat sini dia berdengung sikit suara.
Okey. Mungkin ada 2-3 laptop running tu.
So, sekarang ni kalau Prof. Azman cakap saya tak berjelas kan. Tapi dia jelas dengan sana. Okey. Hello Prof, okey dah sekarang?
Saya clear, jelas?
Okey jelas ya. Okey sekarang dah jelas. Kena pakai Bluetooth saya sini. Okey, jadi nanti we will play your slide. Nanti tell me what to do lah. Just tukar slide mana dia.
Tak apalah, just tell what ada ni lah, don't worry, insyaAllah. Saya rasa saya dikurangkan masa saya 3.10 hingga 4.10, something like that.
Betul.
InsyaAllah. So how are we going to do it? Is it just your discussion ataupun purely presentation? Itu nak clarify dengan you so that I can
arrange. Your presentation. After that, we have Q&A session, discussion, question.
Okay. So kalau what I'm going to do, I will just confine my talk to.
Hello. Hello, Prof. Ya.
Prof, tak dengar.
Tak dengar.
Yeah, sorry. So I will present about 35 minutes to 40 minutes, and then after that 20 minutes to allocate the time for discussion lah. Kalau ada soalan ataupun kalau Prof. Saleh sendiri boleh tanya as we go along after my presentation lah. That's my suggestion. It's more like panel session lah, rather than lecture based. Is it okay with you?
It's okay.
Okay.
We're going to allow Dr. Natasha to present first. Lepas tu Prof. Razman dan terusnya dan Q&A question lah. And both of you get ready to answer the question. Okay.
Thanks. Saya tutup video dulu. Okay, bye.
Okay, boleh. Insya. So yang Naurasha nanti kena on dia punya PowerPoint.
Ada apa-apa lain yang saya sign ke? Ini ada tisu ke, Sir? Sir? Berikut saya nanti cuba adjust naik sikit je, ada 2 inci ni. Kadang-kadang saya tak nampak yang tu bila saya nak pakai lap ni, mic ni.
Good afternoon, ladies and gentlemen. As the conference will be commencing shortly, may we invite everyone to kindly be ready. Thank you.
Connect positive.
Mute.
Sorry for the technical issue. All praise be to Allah, the most gracious and the most merciful. Alhamdulillahi Rabbil Alamin, wassalatu wassalamu ala ashrafil anbiya wal mursalin, wa ala alihi wa sahbihi ajma'in. Assalamualaikum warahmatullahi ta'ala wabarakatuh, and greetings to all our key speakers and all the participants. Welcome to the first 2021 East Coast Surgical Virtual Symposium. My name is Dr. Ikhwan Mustafa, and I shall be your MC throughout this symposium. I hope everyone has had their lunch. As we all know, conferences after lunch hour tend to be slightly crucial in terms of giving out attention. Nonetheless, we hope everyone is in their best health and iman, inshallah. Before we embark on our 3-day symposium series, let's put our hand together for Dua citation. Al-Fatiha. Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alamin. Wassalatu wassalamu ala Sayyidina Muhammad wa ala alihi wa sahbihi ajma'in. Ya Karim, Ya Wadud, sesungguhnya kami berhimpun pada hari ini bagi menyatakan kesyukuran di atas kurniaan-Mu yang tidak ternilai. Jadikanlah kami hamba-hamba-Mu yang sentiasa bersyukur sama ada nikmat yang sedikit, lebih-lebih lagi nikmat yang melimpah ruah kepada kami. Ya Allah, Ya Rahman, Ya Rahim. Engkau berkatilah dan Engkau rahmatilah perjalanan majlis kami pada hari ini. Sesungguhnya Engkau Maha mengetahui bahawa kami di sini ingin menimba ilmu-Mu yang sangat luas bagi mengembangkan ilmu pengetahuan kami sebagai hamba-Mu yang Engkau redai. Justru itu, berkatilah dan rahmatilah perhimpunan kami ini, Ya Allah. Kurniakanlah kepada kami ilmu-Mu. Sinarilah hati-hati kami dengan cahaya dan hidayah-Mu. Semoga dengannya kami mudah menerima dan menghayati serta mengamalkannya. Ya Zal Jalali wal Ikram, kurniakanlah jua kepada kami kesihatan anggota, kecergasan minda, ketenangan jiwa, kekuatan semangat. Semoga dengannya kami mampu mendapati cabaran, berdaya saing dan mampu mengangkat martabat diri, agama, keluarga, masyarakat dan negara. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina azabannar. Wa sallallahu ala sayyidina Muhammad wa ala alihi wa sahbihi ajma'in. Walhamdulillahi rabbil alamin. Surgery has become an essential component of healthcare worldwide. However, major complications are reported in up to 15% in industrialized countries, with 1% mortality or permanent disability rate. Hence, in the effort to raise the concern and standard of our surgical care, Safe Surgery Saves Lives has been chosen to be this year's theme of symposium. This year's captivating symposium features among the established key speakers, Dr. Nur Aisyah of Ministry of Health Malaysia, Prof. Dr. Razman of National University of Malaysia, Prof. Dr. Nasir Amjad, Associate Prof. Dr. Junaini Kasian, Associate Prof. Dr. Islam Munjeh, and Assistant Prof. Dr. Faizal Uthman of International Islamic University of Malaysia. Just a little housekeeping. If you have any questions during the presentation, please type them in the question box in your Zoom control panel. We'll bring them up during the Q&A sessions. Kindly mute your microphones at all times throughout the symposium, and please register the symposium through the link provided in the chat box to claim your CPD point later on. To begin this program, please welcome the chairman of the organizing committee of 2021 East Coast Surgical Symposium, Associate Prof. Dr. Mat Saleh Sarif, to give a welcoming speech.
Thank you, Mr. Chair. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And good afternoon. It is my great pleasure to welcome you all to this East Coast Surgical Symposium with the theme this year, Safe Surgery, Safe Lives, Enhancing Surgical Safety. We're all online to you from Sultan Ahmad Shah Medical Center and the Kuliah of Medicine International Islamic University, Kuantan, Pahang. This program is made possible by the tremendous support from the Department of Surgery, SASMEC, and Kuliah of Medicine, with collaboration with the Safe Surgery, Safe Life Steering Committee, Ministry of Health, Malaysia. So the main objective of this program are first to disseminate information on the various aspects of related to patient safety, the Safe Surgery, Safe Life program, and the Safe Surgery, Safe Life checklist. Secondly is to highlight and discuss common issues and challenges in the implementation of Safe Surgery, Safe Lives. We are very grateful today to brought experts from Ministry of Health and University Kebangsaan Malaysia, as well as our local speakers with who will share their in-depth knowledge in this area. For your information, this course surgical symposium is divided into 3 different dates so that the participants would not be overwhelmed with the amount of information shared during this program. For our first session today, we will hear input from Dr. Nur Aisyah Abu Bakar. She is a public health consultant and Deputy Director of Medical Care Quality Section, Ministry of Health. On the topic of introduction to patient safety, safe surgery, safe lives program, and burden of safe surgery. Then followed by Professor Dr. Razman Birjarmin, who is the Director of Hospital Chancellor Tuanku Mukris UKM Medical Center. He will enlighten us on overview of SSSL, guideline, and checklist implementation based on the HUKM experience. Our second and third session will be conducted on the 13th and 20th of September. Participants will be presented with various input on SSSL from our other expert panels. I really hope that the participants take this great opportunity to learn and embrace the new knowledge and values that will be shared to us by the expert panels. We need to always remember that our work is part of the ibadah, and the burden of which is part of our responsibility as healthcare workers. Before I end this speech, I would like to thank everyone, especially Prof. Dr. Saufi bin Awang and Prof. Dr. Jamaluddin, the Dean of Kuliah of Medicine, for their support of this event. Furthermore, I am very grateful to all the speakers, either from IIM or other institutions, not forgetting my hardworking organizing committee. We want to apologize for any inadequacy or issues that may crop up during this program. We will try to our best to ensure that this symposium will benefit all the participants. With that, Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Prof, for the warm opening speech. Without further ado, we are pleased to have Prof. Dr. Muhammad Center, consultant neurosurgeon, to deliver his opening speech.
Sorry, we cannot hear.
Thank you, Prof, for the very warm welcoming speech. Without further ado, we are pleased to have Prof. Dr. Muhammad Saufi Awang, Director of Sultan Ahmad Shah Medical Center and Consultant Neurosurgeon, to deliver his opening speech and officiate this year's East Coast Surgical Symposium.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillah, alhamdulillahi rabbil alamin. Wassalatu wassalamu ala asyrafil anbiya wal mursalin wa ala alihi wa sahbihi ajma'in. Praise to Allah subhanahu wa ta'ala, the most gracious, the most merciful, and salam and salawat to Prophet Muhammad sallallahu alaihi wasallam and his companion. Thank you very much to Dr. Ikhwan, the chairperson for today. On behalf of the Sultan Ahmad Shah Medical Center at IIM, I'd like to welcome all the participants locally and outside from Sultan Ahmad Shah Medical Center, and also to welcome all the speakers involved this East Coast Surgical Symposium 2021. Now everything is online now. My apology for the some technical problem the last 5-10 minutes also. I was told that this program is scheduled for the next 3 Mondays, which falls on the 6th, 13th, and the 20th September of 2021, specifically talking about safe surgery, safe lives. All right. So for us from the hospital, as a hospital director, it always has been a nightmare for us, especially when there's a medical legal case. All right. So kami pun tak boleh nak tidur. So that's why there's so many things that we can do. One of it is actually try to minimize as much as possible all these errors. okay, in which at the end of the day, we should be able to give a good quality of services to our patients, right? So the topic of safe surgery, safe life is not something new. It has been talking, WHO has been talking a debate a bit about it for a very long time, right? I think if I'm not mistaken from my reading, 2009, if I'm not mistaken, MOH has already taken a step into making a checklist, right? And I think one of the speaker actually involved in the first edition of this checklist. Now, when we talk about safe life, safe surgery, we should make this topic as a promotion. Okay, like today, I like to congratulate the committee members for taking and put forward this topic so that everybody understand about how important about having these procedures at the end of the day will save the patient's life. Number two, which I like to make point here is about the communication. Sometimes there's a lack of communication between surgeon and anesthetists and between the doctors and the nurses. I think the communication skills between these parties must be enforced when we talk about safe life, safe surgery, safe life. And of course, the other thing is about the checklist. We're talking about the pre-transfer checklist. We're talking about operating team checklist. So many checklists. So at the end of the day, the whole purpose of having checklist is actually to ensure that anything that we schedule is planned properly, right? But one thing which I always tell to my staff, that we may have a good policies, we may have good SOPs, but unfortunately, if we do not make this as a culture, that's another problem. So having a good checklist is fine, but to get somebody to do it and follow it and become a culture, that's another challenge, all right? So I don't plan to take too much of your time. I think your speakers is ready. The speaker is already here. Once again, I'd like to take this opportunity to thank everybody for participate in this symposium, and may Allah Subhanahu Wa Taala make this symposium smooth running. With that, saya dengan lafaz Bismillahirrahmanirrahim merasmikan East Coast Surgical Symposium 2021 bertajuk Safe Surgery, Safe Life, Enhancing Surgical Safeties. Sekian, wabillahi taufiq wal hidayah. Assalamualaikum warahmatullahi wabarakatuh. Terima kasih.
Waalaikumsalam warahmatullahi ta'ala wabarakatuh. Thank you, Datuk Sophie, for the wonderful remarks. A few points to remember: checklists, policies, and ultimately culture may lead to safe surgeries, ultimately leading to safe lives. Moving on, I'd like to invite Prof. Mat Saleh here on screen to moderate this afternoon's session.
Thank you, Dr. Muhammad Ikhwan. Assalamualaikum warahmatullahi again, and good afternoon to Professor, Dato, Datin, doctors, and all the participants. Welcome to this first session of this symposium. I will be with you moderating this session. Before we proceed further, a few housekeeping announcements to all participants. Please make sure your microphone is muted throughout the session. All questions must be typed in the chat box, and please state your name and institution at the beginning of the question. I will address all the questions during Q&A session at the end of these two lectures. There will be two lectures during this session. Alhamdulillah, we are very honored to have two eminent speakers today. They are Dr. Nur Aisyah Abu Bakar dan Professor Dr. Razman bin Jamin to the stage. The first lecture is Introduction to Patient Safety, Safe Surgery, Safe Lives Program, and Burden of Unsafe Surgery. Will be delivered by Dr. Nur Aisyah. Dr. Nur Aisyah Abu Bakar is public health physician, graduated from MBBS University, Flinders University of South Australia. She obtained Masters in Community Health, Occupational Health from UKM. She is recently promoted as Deputy Director of Medical Care Quality Section, Medical Development Division of KKM. She was previously the head of Patient Safety Unit in KKM, and actively contributes to the patient safety movement in Malaysia as well as quality in healthcare through policies and program development, capacity building, and creativity. Among her main contributions in Malaysia are the establishment of Patient Safety Unit, Ministry of Health in 2011, establishment of Safe Surgery, Safe Lives program in 2009, and many more since then. She has transformed MOH incident reporting system to online and simpler reporting in 2018. She has been involved in preparation of more than 40 national policies and guidelines on patient safety, quality, and occupational health, organizing and presenting in conference, seminars, and workshops, involved in research, giving training, and become external examiners for public health courses in universities. Internationally, she also involved in the global arena as part of the expert group in WHO Group Patient Safety Network. She has been invited to attend various WHO meetings by various organizations and to present internationally, including the Global Ministerial Summit. Recently, in 2019, she was invited to develop Salzburg Statement on Moving Measurement into Action, Global Principle for Measuring Patient Safety by the IHI Lucian Leib Institute. The passion and commitment in patient safety and quality has managed to bring patient safety in Malaysia to the next level. Now, please welcome our honorable speaker, Dr. Nur Aisyah, to start her speech.
Thank you so much, Associate Professor Dr. Mat Salleh. He is also my friend, when we were in Adelaide. Right, so I have my presentation here that I have pre-recorded. So without further ado, please play the PowerPoint. Thank you.
Of health. Before we start, let us look in.
Can I play? There is one.
Let us look into why patient safety is important. Firstly, it is a principal objective of us as healthcare providers to give treatment to patients and to do no harm to them. We also need to ensure the benefit of treatment outweigh the risk. Secondly, patient harm is the 14th leading cause of the global disease burden, which is comparable to TB and malaria. Thirdly, in high-income countries, as many as 1 in 10 patients are harmed while receiving hospital care. And fourthly, improving patient safety is ethical and moral responsibilities to patients and families. It is also an economic investment for us to prevent patient harm than doing damage control after the harm has occurred. So what is patient safety? There are 3 main elements of patient safety. 1 is preventing harm to patient. 2, reducing risk of unnecessary harm to them to acceptable minimum. And 3, taking actions to prevent harm. Why is patient safety essential? Patient safety is an urgent health issue, not just in low and middle income countries, but also in developed countries as well. Yeah, so it actually put a significant burden to all healthcare system across the globe. Mostly, patient harm can be avoided with simple and effective strategies In most instances, we don't need rocket science to improve patient safety. For example, we can use the safe surgery checklist to prevent wrong surgery and unintended retained foreign body from happening. And furthermore, access to care alone is not sufficient if patients are still exposed to error, and therefore we need to make sure the healthcare system is safe. So why patient harm occur? If we look at this diagram, we can see that patient harm, such as wrong surgery or unintended retained foreign body, can be considered as the tip of the iceberg. Yeah, meaning there are more deeper issues that happen in our healthcare system. Yeah, for example, unsafe acts such as not using the checklist, or unsafe conditions such as insufficient lighting in OT. If we do root cause analysis, we can see.
Tak maaf, I think the sound is very slow. I don't think people can actually hear.
And these system failures can be divided into management and organizational factor, work and care environment factor, task and technology factor, team, staff and patient factor. Yeah.
Boleh, tak boleh.
Now I would like to share with you the statistics on
Belajar.
statistics on wrong surgery in Malaysia based on the reporting that we
Assalamualaikum,
received
Aisyah.
through the
Ini
Malaysian
tak boleh lah.
safety goal system from 2013 until last year 2020. Patient. Okay, if we see here, these are the total number of wrong surgeries.
Assalamualaikum. I think due to technical issue, I think I would like to invite Dr. Naisha to present online. Is it possible? It was recorded presentation. Yes.
Dr. Naisha?
Yeah.
Ladies and gentlemen, it seems that we're having some technical issue as well. The pre-recording has a bit of problem with the volume issue. So if you would mind to give us a bit of time to resolve this.
For Razman, are you around?
Yes, I'm available, Prof. Saleh.
Dr. Najla has a problem with the slide. Are you ready to present?
If you want me to present, I think I can present on my side before while waiting. So I think after that, Prof. Dr. Nur Aisyah can present her subject matter. Because my presentation is more of a discussion of what our experience with regards to, I would say, implementing of this Safe Surgery, Safe Life initiative. But if you want me to present, I'm glad to start first. Would that be okay?
Okay, because he need a bit of time to get ready. I think I get you to present first. Okay.
Right. Thank you.
Okay. I just introduce you, sir. Okay. Because of the technical issue on the first presentation, I would like to invite Prof. Razman bin Jaramin to give his speech on overview of SSL at UCAM, and probably you want to share with us the UCAM experience. Prof. Razman is a consultant surgeon specializing in hepatobiliary and pancreatic surgery. He graduated from UCAM with MD back in 1994 and completed his postgraduate training in general surgery at the same university in 2001. He obtained the fellowship in hepatobiliary and transplantation surgery from University of Melbourne in 2006. He was appointed as the head of hepatobiliary and pancreatic surgery unit and the head of department of surgery at UCAM Medical Center in 2000. In January 2016, he was appointed as Deputy Director, Surgical Services, and now he is the Director of Hospital Chancellor Tuanku Mukris UCAM Medical Center. His expertise includes complex biliary and pancreatic surgery. He has involved in training of postgraduate and fellows in the field of hepatobiliary and pancreatic surgery since 2008. He is active in research and scientific activities in Asia Pacific. He has regularly been invited to teaching faculty and international to the field of hepatobiliary surgery. Without further ado, I would like to invite Professor Dr. Razman to give his talk. Silakan, Prof.
Thank you, Prof. Saleh, for a kind introduction. Just before that, can I just get the technical team for me to use my own slide? Because I think there's some problem in the slide that has been presented earlier.
Okay.
So is it on now?
Yeah.
Is the slide in a good position? All right, I think.
Can you make it in full screen, Prof?
Was it?
Can you make it in full screen?
Right, I'll give you a minute. Yeah. Are you okay now?
Yes,
thank you.
Good now.
I think Safe Surgery, Safe Life initiative is something that has been discussed for so many years. The initiative by the World Health Organization in the early years, I think a few years ago, had shown
Safe surgery, safe life.
How the Safe Surgery, Safe Life has helped us in improving our surgical outcome, improving the safety, and I think how we arrange in the sense that I think we are able to prevent any mishap that had happened before. And I think for us being in the universities, I think you know that a few factors of World Health Organization will be inclusive of the team. There are 10 objectives that we are well aware by the World Health Organization when they initiated this concept that the team will operate in the correct patient at the correct site. I think this is something that very peculiar, especially amongst the surgeons, and particular in orthopedic surgeon, as you're well aware that I think we have a pair of hands, we have a pair of legs. Sometimes I think if this is not being done properly, there will give a risk of operating on the wrong side as well. And this has been reported a few times, which I think Aisha will present later. And you are well aware that I think another objective is basically where the teams, especially in the operating theatre, will include anesthetic teams. And I think although that their responsibility are supposed to protect patient from the pain, making sure that the anesthesia drug that we're given are quite safe, these are the things that need to be clarified accordingly. And then I think recognize and effectively preparing a life-threatening loss of airway or respiration function, especially by the anesthetic team. There's something that we have to recognize. I think with regards to the management of blood loss, I think this is very important part of the World Health Organization of safe surgery, because you know blood are very important commodity, and I think if we are not taking care of using the blood effectively, then there will be carry higher risk of blood loss, hence worsening the surgery itself, and eventually will give a life-threatening situation. And another factors like I think medication, adverse drug reactions, allergic reaction, which is known to be significant risk to the patient. Nowadays, I think we are fully aware of those risks, and then I think a lot of effort has been made in order to reduce those risks. And yet, there is still cases where happens of adverse drug reaction that can be life-threatening. That's why I think it's very important for all these measures to be acknowledged. The other thing is that with regard to the surgical site infection, there will be another factors that we have to be aware that I think the initiative of surgical site infections where there is what we call a stewardship programs for pre-operative antibiotic utilizations. These are the factors that are part of the overall strategies, which also include of the managements of the peri-operative care, intraoperative care, and other things. That's why I think this is where the role of a contamination class of the wound and eventually the management accordingly. Another important factors of World Health Organization objective of safe surgery, I think, although that it has been known that I think these are relevant to our practice, especially to prevent inadvertent retention of instruments or sponges in surgical wounds. That's why I think we are very particular on all this. I think the team has to be very clear of what has gone into, especially into a laparotomy wound or other wound. And sometimes when you have significant bleeding, the sponges that have been put into the wound will be not recognized. And when too many activities happening, no one monitor the outcome or the findings, and eventually it was accidentally inserted in the wound itself. And that create unnecessary complications, and even worse if the complication led to a life-threatening situations. And also, I think another important factors will be identifying all surgical specimen, because you know that surgical specimen are very, very precious. It's very important to manage them, especially as oncological surgical specimen, because it will determine whether your oncological resection has achieved its target. It also determine whether you have done the right labeling and everything, so that eventually the reporting will be more appropriate and accurate. I think you had heard about cases where performing appendicectomy and eventually histopathology report came back as adnexia of the fallopian tubes. These are the things that you want to avoid, because it creates unnecessary complication, but more important, it creates unnecessary litigations to the medical practitioners. And I think when I think Dr. Saufi, in his opening remarks, the important effective communication, I think that's very important and it's very critical for the patient information to be relayed clearly between the practitioners, making sure that safe conduct of the operation between the teams has to be done properly so that we don't miss unnecessary miscommunication. And even the communication between the anesthesia, the surgeons, because I think while we operate, we are not working in silos. We have to work together. And all this hopefully will improve the risk of safe surgery and eventually reduce the risk of unnecessary complication, which eventually will improve the surgical outcome and betterment for the patient recovery. A very quick how this Safe Surgery, Safe Life initiative started, especially in our country, in Malaysia. I'm not going to go detail about this because I'm sure Dr. Nur Aisha will be presenting this because I think she is one of the pioneer that I'm sure she was since 2008. I think this proposal started when the WHO initiated the concept of Safe Surgery initiative. And eventually it grew, yeah. And some of it was implemented, and until now it has been used as a standard setting for most of the hospitals in the country, either private or public. And it has been an important element for MSQH. I think that is the document 11, where the operative theatre play a very important role in terms of training, in terms of safety, in terms of responsibility and everything. And I think when we started eventually in 2010, our hospital, Hospital Chancellor Tuanku Mukris, was part of that initiative. Alhamdulillah, I think over nearly 10 years we had involved, and I would like to share our experience later with the audience, and hopefully we can generate some discussion after this. Now we have achieved 24 years of our hospitals. We started in 1997, and until now we are considered one of the important landmark hospitals in Klang Valley. We give a lot of contributions to the hospital services, medical services and surgical services, particularly to the community and also to the country. We train postgraduate trainees, undergraduate trainees, and also subspecialties. And I think being a very important hospitals, we also put the potential of exploring new technologies and new techniques. This is important, especially being a teaching hospital. At the present moment, when come for operation or surgeries, annually we have about 20,000 cases of emergency and surgery and elective surgery being done at our hospitals. We have three theatres complex, the main theatres, the obstetrics and gynecology and emergency theatres, and we total up about 24 operating theatres. That's why it's very important for us to make sure that I think the initiative of Safe Surgery, Safe Life being implemented in the full manner at our hospital to make sure that I think the service has been given and then being done in a proper manner. We can't afford to have any unnecessary complications, any unnecessary implications to our patient, because being a tertiary center, most of our cases are complex cases. Therefore, I think by making sure that the initiative of Safe Surgery eventually will improve the life and outcome of the patient and eventually will reduce unnecessary complications, therefore reducing the morbidity and mortality of our services. What is our strength? I think with regard to us, I think beside the service that we provided, our strength also comes in training. And I think that's why it's very important. Being a teaching hospitals or what we call Hospital Pengajar University under Kementerian Pengajian Tinggi. I think it's very important that we make sure that our practice are in line with the Ministry of Health and also in line with World Health Organization. We have to make sure that all our trainees are being trained properly, especially in dealing with this kind of situation. We have to make sure that our trainer comply to the standard that has been given, although it's big challenges, which I will discuss later. But I think we also have to make sure that our resources are being utilized properly. I think running 20 theaters a day, we create a lot of chaotic situations. And sometimes these cases are not one unit management. Example, if you are doing some small session of the lung, but if you need to do a bigger multi-complex and then multidiscipline where involve, example, the orthopedic surgeon, the anesthetic, the general surgeons, or even the vascular surgeon. So you need a well coordination. And through these implementations of Safe Surgery, Safe Life initiative, we are able to do that accordingly, making sure that I think prevent the risk of development. And Alhamdulillah, I think so far since we started, we do have a few, I would say, minor mishap, but I think comparing with the total outcome, I think we've been reasonably quite good in handling this kind of situation. If you notice that, I think we do complex cases, like examples in morbid obesity surgery, where you handle about 100 to 150 kilograms of patients. Can you imagine handling the patient right from the wards, going to the theaters, preparing the patients on tables? Therefore, I think this kind of safe initiative needs to be done. The pre-operative checklist has to be done clearly. The operative checklist has to be done clearly so that we don't miss any issues, because you can't afford to have any complications towards this patient. Even a simple endoscopic procedures that are being implemented even in the procedure room, like a daycare services. I think if we don't have this concept of Safe Surgery, Safe Life initiative, that will create an unnecessary complications that may develop. I think the challenges, which I will tell you later, is where when we have our turnover of the patients, quite significant turnover of our doctors also being a training center. They are not with us a long time. They always rotated. And that's give a challenge being in the teaching hospitals, especially in HCTM, to make sure that the practice or habits of Safe Surgery, Safe Life initiative being implemented accordingly. And I think this initiative has to be also being implemented as we go along the safety limit. If you notice this, I think in this era of COVID, where we design a very simple initiative, although that in COVID era, we're performing endoscopy, also that this is quite considered aerosolized procedures by preventing our healthcare. We are still able to protect the patients from breathing through the mask, and yet we are able to do the scope in a proper manner. So these are the initiatives that we are doing, and then this part of our strategy in reducing the risk of the patient from having any untoward complications. Again, I would like to stress out the importance of communication, because I think effective communication will give all this outcome, positive outcome. I think poor communication will definitely bring a risk to our services. Poor communication will also give a risk to the patient. I wouldn't go in detail into effective communication, because I believe there is a session for effective communication. But I think more important, I would like to stress out here, importance of with effective communication, we have better response from all stakeholders. When we say all stakeholders, meanings the operating surgeons, the practicing anesthetists, and also inclusive of the nurses, right from the nurses from the ward, from the reception, the operating theaters, and also recovery, or if necessary, the staff nurses that require an ICU. That will give a better control to the managements. Therefore, we will give a very professional image on solving the problems, and we are able to make a better decision making. And in overall, with this kind of activity, we should be able to give a better productivities and consistent in our flow. I think that's a concept why, if you notice the Safe Surgery, Safe Life initiative, although that I think is just a simple process, but if we don't consistently doing it, we are not able to achieve the standard that has been put by the Ministry of Health. I think if we consistently doing it, becoming a practice, and eventually once the practice has been consistently being done, it will become a habit, and then eventually it become a culture. And that's what we want, a better culture for betterment of our patients. I think one important highlight that I would like to bring here is the organization. I think the role of a surgical safe surgery hospital committee is very important, and how we develop this also is very relevant, because I think appointing someone without interest will create a disaster, because to them it's just a directive and they are not able to enhance the potentials. What we have done here in Hospital Chancellor Tuanku Mukhlis, we have reorganized our hospital committee on safe surgery. If previously what we have was only what we call a Jawatan Kawasa Dewan Bedah, or just a committee to look at the operating theatre. But what we found that if that administrative works only, but no input directly from other people, that create an unnecessary problem, because we are not able to implement any program effectively. I think that's why I think in 2015 we have to reorganize our hospital committee operating theatre. Then this is where we will manage to make the Safe Surgery, Safe Life initiative more effective. And another enhancement that we have done, basically we have strengthened our peri-operative antibiotic prophylaxis program through our stewardship programs. And we have also improved our patient safety council activities, and hand hygiene also been implemented through this approach. And another important factors of incident reports, especially in operating theatres. I think that's a very important element that we need to do in order to improve our safety, and also especially in operating theatre. And these 9 criteria that has been put in the MOH guidelines on how to improve this Safe Surgery, Safe Life program, I think we had implemented appropriately. And at the present moment, we are in the phase of monitoring and evaluating the implementation and effectiveness of these programs. And so far, I think the strengthening has been done, and we are able to enhance this. I think for any operating theatres that want to have, I would say, a safe criteria for your patients, for your staff, for your doctors, you have to adopt the Safe Surgery, Safe Life initiative as whole. You cannot take it partly and don't implement other part. You have to make as a whole, basically direct from the pre-operative, intra-operative, and post-operative care. I think this is where we can make sure that our patient safety being taken care appropriately, and eventually we create an innovative improvements on surgical safety. And examples of what we have done here at the present moment, based on this, the recommendation, the chairman should be surgical or surgeons, vice chairman, anesthesia or surgeon, and then the secretariat. We had basically adopt this, but I think with some modification. We have a secretariat for the operating theatres that not only looking in charge of patient safety, but the secretariat also look at the overall activities in the operating theatre, like your administrations, your resources, your logistics, your assets, and the financial management, because I think that will give the whole activity under this council. And at the present moment is being led by an anesthesia, which was appointed by the hospital director. And the committee will be responsible or answerable to the hospital managements. And all our representative are either head of department or representative, either surgical-based discipline and anesthesiologists. So if you look at this model, it shows that everyone has its own responsibility and role, and everyone have a say on how to improve this. And at our levels, I think we also include our pharmacists, our security team, even our IT team to be part of the initiative. Beside that, the nurses has to be there. Our nurses manager has to be there because they are the one that will be the implementer of this activity. I'm not going to go further on all this. These are the guidelines. You can Google through, or you can get a copy. What are the guidelines of the Safe Surgery, Safe Life programs? I only included this peri-operative checklist and also operative checklist before inductions. There should be also another post-operative checklist as well. I think these guidelines are very comprehensive, and I think I'll strongly recommend of any hospitals, if you have not done so, to accommodate this kind of a checklist. I think to me, in my opinion, we have used it in appropriate manners, and we had done some modification to improve the checklist in order to make it much better, but this only for the local use or hospital use. I think based on this initiative, the other factors that we have is that we have, I think MOH also had done that, where we have changed our consent. If you remember last time, a few years ago, the consent only just one piece of paper, one page, and this is where all the detail being listed out. But nowadays, I think the patient are much more knowledgeable. They were able to get more information through the internet, through the social media. Now, I think even the consent has been divided into two categories. Basically, the anesthesia consent, also the surgical consent or procedural consent. This is how we evolve. And I think that's very important for us to make sure that all the information given, all the consent taken are protecting all parties, not only patient, but also protecting us as a practitioners. Because I think nowadays, you know very well, the litigation are very, very easily to happen, and we can't afford to do this. And I personally using this pre-operative checklist, in particular for the operating team checklist, I find it very useful. And I think, in my opinion, it has improved my intraoperative communications, either with the surgeons, other surgeons, the anesthesia, and also the nurses. And I think because I've been practicing it, it has become not only a habit, but I think it become a culture to me. And I think this is something that we should learn, and making sure that our juniors learn this. Sometimes people will feel that in theater, when I start making noises, example, such a control orders or demand, but that's not for the sake of saying it loud, but I think it's such of how we, what we call a shout out and all this. Example, if I need to put the abdominal pack in the abdomen, I will tell whether this is a second pack or third pack or fourth pack in, so that the rest of the team will be aware how many pack is in and how many will be taken out. And also very clear for the nurses, because you know that sometimes the activities that happen, if it's a long surgery, even the nurses team will change. You know, you have the morning shift change to the afternoon shift. So the passing over need to be done in the proper manner, so that we are clear that we don't miss anything. Because even a simple gauze, if we miss, that create unnecessary complication to the patient. So I think, again, improving communication and teamwork is very important to ensure safer surgery. Because I think by using this surgical safety checklist, I think I had shown that it has improved the standard of surgical safety, reducing the error margin, and eventually reducing the risk of litigation. What are the challenges, other challenges on managing surgical safety Safe Surgery, Safe Life initiative. From my perspective, I think being a surgeon, performing major cases, because I'm hepatobiliary surgeons, you can imagine handling sometimes trauma cases with active bleeding and everything. So these are the things that I found from my personal experience being a director of the hospitals. These are the challenges. One, we are fully aware that I think operating theaters are basically is a war zone, because I think it's combined of multidisciplinary healthcare personnel, although their aim was to give a high standard of comprehensive patient care or procedures. But then the challenges is that I think when you have so many multidisciplinary healthcare personnel and then with different kind of opinions and sometimes no clear directive, and that create an unnecessary unhealthy situation. Sometimes I think if the checklist was not done proper, the surgeon was not there, the anesthetist has induced the patient, and the surgeon was nowhere around. This shouldn't be happening. With this kind of safe surgery, safe life, everybody should be there before we start on anything to making sure that everything is being taken care properly. And I think handling multidisciplinary healthcare personnel also is very important. Although it used to be a one-man show last time, but I think at the present moment, it has to be a team effort in order to improve the situation. Each aspect of the work, we have to provide a very coherent working relationship. Even calling the patient from the ward, coming to the theaters have to be done in accordingly, because you don't want to delay the delivery of the patient, and yet you don't want to miss a lot of factors. Making sure that patient comfort, dignity, and safety is very important measures. As a team, we have to make sure that we keep the patient privacies and dignities. We have to be very professional in handling this. More important, I think, although the operating theaters is war zone as I described, but I think if we use the Safe Surgery, Safe Life initiative, the culture of safety and evidence-based practice can be implemented expectantly. The expectation of patients are very high nowadays. I think we have to make sure that we comply to those expectations. But when I say expectation, it's within the standards of care that we are giving, not the expectation of demanding of patients. I think this is where when you have this Safe Surgery, Safe Life checklist, you can improve this workflow. The other factor is the compliance of regulatory and statutory requirements. I think that's a very important. That's why everything that we do must be documented appropriately. And furthermore, nowadays with the new technology, sometimes the industry want to have us testing this, testing that, certain instruments. So we have to make sure that they comply to the regulatory that we have performed. Because any new device that has not been tested properly, being used to the patients, we should prevent that, because I think it has to be done in a proper manner. Patient is not a guinea pig, they are our patients. So we make sure that I think any new thing that we want to introduce has to be done according to the regulatory. Although that a new company comes with a certain evidence saying that this is a good product, please try on your patient. Sometimes I'm a bit worried because we never know. But this has not been tested and has not been approved accordingly. More important, if you notice MSQH requirements, especially as I mentioned to you just now, if any of the hospital want to implement or want to adopt or want to get MSQH certification, document 11 are very important, because you need to comply to the Safe Surgery, Safe Life initiative. You need to comply to the standard of the Patient Safety Council. You need to comply to the blood transfusions regulatory bodies, making sure that everything are within in order. That's why I think these are the challenges to me as a director of this hospital, because we are in the process of going for MSQH, but the problem and challenges is that when looking at all these requirements will give us a very mammoth task to develop this. I think probably maybe it'll be different for smaller hospitals or for a new hospital, but I think at 24-year-old hospitals, you know that I think the infra need to be improved. and I think the practice need to be done. And the other challenges with regard to the financial management is also important. Nowadays, we know that the demand is there, the costs are very high, and I think sometimes unnecessary usage of the instruments, devices, medication can create unnecessary burden to the management and also to the patients. I think we have to use our financial effectively in order to making sure that that I think the money and the finance is being done accordingly. And by having a Safe Surgery, Safe Life initiative, through this we are able to manage accordingly, because I think we found that I think the checklist that we have reduce or minimize the financial excess or burdens. We don't simply open up unnecessary instruments unless if it's required. So I think everything has been prepared accordingly, and that helps to control the financial part of it. With regard to the human resource, teaching hospitals are slightly different compared to the other hospital like the Ministry of Health, because we do have a very high turnover of our trainees, doctors, because here we provide undergraduate training, postgraduate training, and also specialty training. The problem is that when we have a new turnover, and basically these doctors may have a different perspective on Safe Surgery, Safe Life initiative. So these are the things that need to be streamlined at the national level, so that all the doctors in our country are very well versed with this kind of activity, so that when they go to any hospitals that practice a Safe Surgery, Safe Life initiative, they don't have any troublesome coping with the new environments. We find it a bit difficult sometimes because their practice may be slightly different than our hospital, but over time they will improve. And the other another issue, the human resource with regard to the staff, or basically the nursing staff. I'm sure that you are well aware that at the present moment the high turnover, especially on our operating theatre nurses, because they are in high demand. Well-trained nurses, it takes about 5 years for us to train them before they are become fully well-versed and fully trained and very experts. Unfortunately, because of these other factors like financial commitments, family commitment, they have to leave our facilities, and we have to start new for some of the staff. That's why I think it's very important that this Safe Surgery, Safe Life initiative has to become a culture. If you have a culture within us, then the training of the new staff will not be so difficult, and eventually they will accommodate and then will assimilate with what we are doing. Another challenges in the teaching hospitals with regards to the new technologies, because I think being a teaching hospitals, we require constant learning. And then I think sometimes new technology comes in when we have our doctors, our surgeons come back from overseas with new skill sets. So these are something that we have to adopt and adapt, but still within the limit of this checklist or Safe Surgery initiative. Because I think end of the day, whatever new technologies that comes in, the patient safety is very important. We can't afford to prevent unnecessary risks to the patient or unnecessary complications. That's why sometimes at our level, when it comes for new technologies, the acquiring surgeon has to come and request for some credentialing or privileging for that thing in order to make sure that they are in the right platform to perform these procedures. Because we have to make sure that the surgery is safe to our local populations, because these technologies in overseas may be slightly different as compared to what we have here. And I think it's very important with that new technology, because he has to be trained, and we have to train our staff so that they are very familiar with those kind of activities. The other challenge is with regard to the multidisciplinary management in theatres. This is another big challenge, especially for trauma cases. Examples, you have a polytrauma cases, the orthopedic want to go in, the surgeon want to go in, and it really like a market sometimes, and then you know that in a very unstable patients. We do had cases where sometimes I think that one case reported at our centers where some abdominal gauze was misplaced inside, but after closing, then only we realized it. But in view of the instability of the patient, and during that period also, it was an abdominal packing was done. So we knew there was additional unintended, I would say, gauze was there. So we made sure that on the next re-laparotomy, we took out that gauze. So, but it's still reported as a, I would say, missing a gauze. And I think that's why I think when come for multidisciplinary issues, you need a good command or leaders to make sure that all activities are done in a coherent way and all activities are being done in the systemic manners, and then the priority being made according to the level of difficulty or level of critically patient conditions. I think that's very important, especially for all the practicing surgeons. In trauma is much difficult because it's immediate decisions, but in elective setting where you need a few disciplines to be done, sometimes it's good to handle it pre-operatively. For a major case, it's better to have what we call a multidisciplinary team that inclusive of the anesthesia, the nursing, all the surgeon to sit together before the surgery to decide what is the steps need to be done. And I think by having a pre-planned, that is an adjunct to what we already have on Safe Surgery Initiative, because it will help us to coordinate better, therefore reducing unnecessary procedures to be done on the patient, and then in a timely manner, so that everybody will be done in an according manner. So those are the challenges that we have, and I think to me we need to make sure that these are being taken care of properly, especially in our facilities. As I mentioned again, when it comes for new standard operating procedures and guidelines for improvements, quality assurance is a must for any OT committees to improve your quality or standards, making sure that safe surgery is being done. We had routinely now making an incident report, even a simple matters is important, because to us, if we keep it quiet, that thing will just keep on growing. That's why even an incident report will help us be prepared on any untoward incident in future. That's why I think it has been a practice now for incident report to be reported by anyone that involved in it, and eventually investigation will be done accordingly. The other thing that I think we need to make sure that our improvement of the cancellation rate, I think that's another challenge that we have, especially in our operating theaters in general in Malaysia, because the moment you cancel the cases, sometimes in order for you to reschedule them, it's not easy. Sometimes it takes longer. So I think that's why it's very important as part of our new strategies to improve cancellation rate. Therefore, I think that will also improve the patient outcome. I think that providing the peri-operative facilities also is very important. That's why I think the importance of the pre-op checklist and then the discussion with the team, making sure that this patient do have this requirement. Example, like if you need ICU backup, or do you need only a PACU backup? These are the things that we need to prepare accordingly. And finally, I think more important, I think by having this Safe Surgery, Safe Life initiative, hopefully we can improve our daycare services, because I think by improving daycare services, the patient can be in hospital, therefore reduce the burdens of the hospitals and the financial, and yet the procedure can be done. Nevertheless, the biggest challenge now is COVID-19. This is something that we are fully aware, and although that it will become endemic to our population, I believe this is something that we as a practicing surgeon and also administrator need to be aware what will be the new norm that we need to adopt and adapt with regards to the COVID-19. You have seen how our surgeons are operating in the I would say high-risk environments, wearing TVAX, PAPR. We need to prepare all this, because these are the requirements for us to improve this safe surgery and also saving our staff from getting infected. And I think this is not a new norm, which eventually will become a norm and eventually become a habit of us to manage this COVID-19. I had experience operating on COVID-19 patients, and I'm telling you, if you have not done it, it's very, very interesting experience. But I'm sure, inshallah, it will be something become a normal activity for us once we are adapting to this environment. With that, I would like to close my presentation on our experience, Hospital Chancellor Tuanku Mukhlis experience of Safe Surgery, Safe Life, with the final word, lindung diri, lindung semua. Assalamualaikum warahmatullahi wabarakatuh.
Now I think I would like to invite Dr. Nur Aisha to start talk now.
Can you upload my presentation, please?
Okay, I'm doing.
Right, can we make it bigger?
Is it okay, Dr. Nur Aisha?
Yes, okay, great, thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a very good afternoon to everyone. Can everyone hear me clearly? Great, okay. Sorry for the technical glitch just now. I actually pre-recorded my presentation, but somehow it was not very clear in terms of the voice. Right, okay. So first of all, I would like to thank International Islamic University Malaysia for inviting me today. So I will share my experience on patient safety as well as burden of unsafe surgery and Safe Surgery, Safe Lives program. My job today, my task today is not very difficult since Prof. Dr. Razman already explained in detail about how safe surgery has been implemented in his hospital. Next one, please. Next slide, please. Okay, before we start, I just would like to emphasize about patient safety. Yeah, why patient safety is important. First of all, because it is our principal objective as healthcare provider to give treatment to patients safely and to do no harm to them. Yeah, and we also must ensure the benefit of the treatment outweigh the risk. Yeah. And for your information, patient harm is the 14th leading cause of the global disease burden, and this is comparable to TB and malaria. So patient safety is very important as patient harm is really a huge problem now, yeah? And in high-income countries, as many as 1 in 10 patients are harmed while receiving hospital care. Yeah, and in developing countries as well as low and middle income countries, you can imagine that the magnitude is actually much larger. Yeah. And patient safety, improving patient safety also is an ethical and moral responsibility as well. And it is cost effective to implement patient safety initiatives than waiting for incident or patient harm to occur and do the damage control after that. Yeah, so preventing is definitely the answer to that. Can you move back to the slide? Slides before. No, one slide before this. Right, okay, great, thank you. Okay, so what is patient safety? Yeah, there are 3 main elements in patient safety. One is about preventing harm. Second is about reducing risk of unnecessary harm to acceptable minimum. And also to take actions to prevent harm. So if we want to implement patient safety, that means we must have all these 3 elements. Next one, please. Right. So why patient safety is essential? Again, I just would like to emphasize that patient safety is an urgent global public health issue, not just in low and middle income countries, but also in developed countries as well. Yeah. And this is actually causes significant burden to all healthcare system across the globe. Yeah, and most of the time, patient safety can be achieved just by a very simple strategies. Yeah, just like using the safe surgery checklist. It's not really rocket science, but just by using the checklist, we can actually prevent lots of incident or error from happening. Yeah. And another thing is if we just improve the access without improving the quality of care or the patient safety or aspect of it, it is not sufficient. Yeah. Next one, please. Right. I actually have a diagram here just to illustrate about the seriousness of this patient harm that is happening now. Yeah. So if we look at the page at this diagram, we can see that the tip of iceberg is the patient harm, such as wrong surgery or unintended retained foreign body. And if we go deeper, then we know that the patient harm is a result of unsafe acts, such as not using the checklist, or unsafe conditions, such as insufficient lighting in the OT. Yeah, and if we really investigate and do root cause analysis, we can see that actually this is happened because of system failure. Yeah, for example, due to training not being conducted, or in terms of human resource, there's no sufficient surgeons or staff, yeah, in the OT. And this system failure, we can actually divide it into a few categories, such as the management and organizational factor, work and care environment, touch and technology factor, team, staff, as well as patient factor. Yeah, but patient factor should be considered the least. We need to improve all the others first. Yeah. Okay, next one, please. Right. So now I would like to share some statistics on wrong surgery based on the Malaysian Patient Safety Goals statistic. Yeah. From 2013 to 2020. 2013 to 2020. So if we see here, the total actually is 37 cases, yeah? And over here, we can see that orthopedic cases actually the most, followed by ophthalmology cases, yeah. And after that, we also have general surgery, neurosurgery, and breast, endocrine, ONG, and neurosurgery, as well as dental, yeah. Okay, next one, please. Right, in terms of the type of error, we can see that the most type of error is actually related to wrong side. Yeah, wrong side, that means right. Actually, for right surgery, they conduct left surgery. That's an example, yeah. So wrong side surgery followed by wrong side, wrong implant, and a few others, yeah. Next one. We also had wrong patient case, yeah. Okay, in terms of the number of cases by type of surgery, we can see here that most wrong surgery involve body parts that have right and left side. Yeah, for example, the ophthalmology, eye surgery, craniotomy, and then orthopedic surgery like knee surgery, yeah, arthroscopy, breast surgery. Yeah, okay. Now right. Okay, next one, please. Right, now let me just quickly share with you the statistic on unintended retained foreign body. For this one, we actually get the information from the MOH incident reporting system, because we have more details that I can explain to you. Yeah, next one. Right, so for, okay, can you go back, please? Right. Okay. So for this unintended retained foreign body that we can see here that the actual cases about 102 cases, yeah, which is about 82% of the total 125 cases that reported. This is all Ministry of Health cases. Yeah. Next one, please. Okay, in terms of the type of the foreign body, the most are actually instrument or instrument parts, yeah, and followed by gauze. We also have other things such as throat bag and part of the needles, yeah, but the most are instrument part and gauze. Next one. Right. So in terms of the patient outcome, we are very fortunate because most of the outcome are actually either mild or no harm. Yeah. And the rest we only had 3 severe patient outcome related to unintended retained foreign body. Right. So how can we improve patient safety and surgical safety? Okay, so what we need to do is we need to have all these elements, yeah. First of all, we must have safety thinking, yeah. We must practice safely. We must have safe condition or safe environment. And we also need to improve the whole system, yeah. And it goes from individual action to collective action, yeah. So from individual, each of us as healthcare providers to the whole healthcare organization, yeah. Okay, so next one, please. I will explain to you the details, yeah. This is just a very simple formula that I created just to make people understand and can understand it easily, yeah. So if we want to achieve patient safety, we must have that safety thinking, safe practice, we must have safe environment, and we need to improve the system as well, yeah. Right. So what is safety thinking? First, we need to think of safety at all times. Yeah, when we conduct the procedure, when we do surgery, we must think of patient safety and the safety of the patient as well as the safety of ourselves. Yeah, and another thing is safety definitely involves prevention. Yeah, so we should not aim for damage control after incident or medical error happen, but instead what we need to aim is actually to prevent patient harm. Yeah, and safety is everyone's business, not just the hospital director, but it's involved everyone from the ministry, from the state health department, from the hospital director, from middle manager, the implementers, and various categories of staff as well. Yeah, can you go back, please? Thank you. And also, we need to think that what can we do to improve patient safety? We must have, we always need to think of that. Yeah. So what can we do to improve safe surgery, for example, to improve medication safety? Yeah. And safe practice also save lives. Just a simple practice, just like, again, we go back to the checklist, just a simple use of checklist can actually save people's life. Yeah. Right. Next one, please. Okay, so what is safe practice? Yeah, first of all, before we practice, we must have the knowledge. Yeah, knowledge related to the task that we are going to do. We must have the skill and we must have the competency. Yeah, so this is why the surgeons, the senior surgeons need to monitor the junior surgeon and also the students, for example. Yeah, so this is very, very important just to make sure that you are doing your practice right. Yeah. And we need to follow all the policies, the clinical guidelines, the SOPs that we have. Yeah. And we need to communicate with each other, yeah, within the team and also interdisciplinary, yeah, and this has been highlighted by Dato' Razman just now many times, yeah. So we also need to speak up for patient safety. If you feel someone is not practicing safely, or they they are actually cheating on the use of checklists, you need to speak up and we need to improve on that. Yeah. Okay. And we also cannot be a hero. Yeah. If you are not certain, if you are unsure, don't assume. Yeah. Please ask for guidance and please seek for help. Next one, please. Right, this is just a simple example of safe condition or environment. For example, one of the common issues related to environment is the slippery floor that can actually lead to not just patient, but the staff actually fall as well. Yeah, okay, next one. And this is the system improvement that I'm talking about. Again, if you can still remember the iceberg diagram that I showed, yeah, it's mentioned about system improvement, and these are all the components of system improvement. Yeah, based on my experience, when we do root cause analysis, a workshop on root cause analysis, one of the things that people always highlight is actually, okay, this incident happened because of patient factor, because patient cannot communicate, because patient is this and that. So that is actually the wrong approach. What we need to do is actually to look into other factors first before blaming the patient for causing the harm to themselves. Yeah. So let us look into all this. Yeah. Okay. Next one, please. Right. Okay. Now we go to the Safe Surgery, Safe Life. I'm glad that Dato' Razman already mentioned a lot about Safe Surgery, Safe Life program and the checklist. And the WHO actually started in 2008. Yeah. And we at Ministry of Health also started in 2008 doing the pilot project. Yeah. And see what we can do as a program, a national program. Yeah. And we launched it in 2009. Yeah. And the main objective or the main aim is actually to help ensure that teams consistently follow a few critical safety steps. Yeah. Next one. Sorry. Yeah. And thereby minimize the most common and avoidable risks. Yeah. So what we want to do is to make sure that all the critical steps are followed correctly. Yeah. And we will not forget about that. That's the reason why we have these checklists. Yeah. Okay. Next one. Right. So this is the safe surgery checklist, yeah, and we call it perioperative checklist, and it's very simple and efficient priority checks tool, yeah. So it's a tool that we can use to help us in ensuring that we are not missing all the critical steps, yeah, and it's actually can ensure correct surgery, safe anesthesia, preventing infection, yeah, and also effective surgical treatment is given. Next one. So these are the benefits of checklists. I just would like to highlight this because we still have people who are a little bit resistant on using the checklist, yeah, and some people just are not really into that, yeah. So I think this is very, very important just to convince people that why we need to use checklists, yeah. Okay, one is actually in terms of the organization, it can help individuals to stay more organized and ensure that they don't skip any important steps, yeah. And two, as a motivation, yeah, when you have checklists, you basically want to complete all the tasks, yeah, and take a complete action, and you will not miss anything. In terms of productivity, when we do this regularly, we can actually complete it more quickly and efficiently with fewer mistakes. Yeah. And if we have checklists, our brain doesn't need to use more power, yeah. So it is very helpful in helping our brain, yeah. So we can actually use our brain power for other things, yeah, and we can be less stressful, okay. And then we can also delegate the task to other probably junior staff because we already have the checklist, yeah. And studies have shown that the checklist can literally save lives. Yeah, I will share with you some of the articles that mention about the outcome of this. Right. Okay. So if you see here, initially before WHO roll out this safe surgery checklist, they actually do a pilot project in 8 countries involving 8,000 patients, and that actually showed a dramatic improvement in outcome. Yeah, with 47% reduction in mortality and 30% reduction in complication. And the Netherlands also doing the same thing, and that also show a remarkable improvement in surgical outcome. Yeah, and later on, many studies have been done, and the checklist also was associated with 30% decrease in mortality. Yeah, and as well, not just mortality, but improving surgical teamwork and communication as well. Yeah, and then in another article, it says that there was a strong correlation between a significant decrease in post-op complication and adherence to aspects of care embedded in the checklist. Yeah, so it's so we are very convinced that the checklist actually have a significant positive outcome. Next one, please.
Makan KFC. Mesti ni penuh dah telefon. Makan KFC. Si manduk nak tarik narai.
Okay, sorry for the interruption. Yeah. Okay, the next one. This one is our Ministry of Health primary team checklist in orange color. Basically, what we do is we actually use the WHO checklist and actually incorporate that into our existing documents. Yeah, that we have used before. So it becomes a 4 pages document. Yeah, and it consists of pre-operative checklists that we need to fill in the ward, and then the operating team checklist that we need to fill in the OT, yeah, including during a timeout, yeah, and swab and instrument count form we also incorporate in this document, as well as the pre-discharge checklist. Yeah, so so this is the Malaysian version of a safe surgery checklist. Yeah, next one, please. Right. So the one in blue color is actually the multidisciplinary checklist that we have added when we actually produce our second edition safe surgery guideline. Yeah? This is because many surgeries involve multidiscipline. So we must make sure that all the other disciplines also complete the checklist using this blue color checklist. Next one, please. Right, and I just want to emphasize again about the circular that came out together with the new safe surgery guideline in 2018, yeah, and we also emphasize on a few other things like how to do site marking, communication in terms of improving communication, yeah, and also the governance of the safe surgery program. So we have added another layer, which is basically a safe surgery committee at state level. Before that, we just had a safe surgery committee at a hospital level. Yeah, so at state level, the chairperson is a surgeon. Yeah, okay, next one, please. Right, so this is briefly the governance structure. So we have the steering committee at ministry level. So we are the technical secretariat, and we have been involved in this since the birth of the safe surgery program, yeah, headed by Dr. Jamil, yeah, and he's already retired. Now we have Dr. Anwar Hao, yeah. Okay, and at state level, we have also another committee, and at hospital level, we also have committee, and this one has been shown by Dato' Razman just now, yeah? Okay, so next one, please. So, okay, so now actually in Malaysia, we are among the leading countries in safe surgery, whereby we actually managed to implement it throughout Malaysia, yeah, not just in public sector, but also in private sector. But despite the implementation, some hospitals are a little bit reluctant in implementing it properly. So why these are happening? So I actually, we actually managed to get some feedback, yeah. And these are the reasons why they are not implemented properly or effectively. Yeah. So some people just deny the benefit of the checklist. Some are not very familiar with the checklist. And some people thought that a checklist is just about ticking the boxes exercise. Yeah? So they just tick and tick and tick. Yeah. So what we need to do is actually to explain to them why this checklist is important and how to do it correctly. Yeah. So we actually had an experience whereby we see that this hospital has, like, when we do audit compliance to the safe surgery checklist, we see that this one hospital has 100% all the time. Yeah. And we actually asked them why this happened. You know, what's your secret? But then the sister, the nursing sister said to me, Dr. Aisha, if we didn't see if we see that the ticking is not complete, then we just tick everything. So okay, so that's the reason why the compliance is 100%. Yeah, so we really need to go and ask the details. If it's completed 100%, what's the reason, and then we know what's actually happening. And some people don't really understand the philosophy of this checklist. Yeah. Okay, and then the coverage of training sometimes are not sufficient, yeah, and it's not effective. And like what I mentioned, staff does not understand the importance of the program, and there is no support from leaders, from the hospital director, from the hospital, from the head of department, yeah, and from the other team members as well, yeah. And lack of safety culture. As mentioned by Prof just now, you know, safety culture is the foundation to patient safety. We must have that culture, and we must have that safety thinking, yeah. So without that, it's quite difficult to implement something which requires perseverance, yeah. And some people just don't want to change, yeah, and they are very complacent with the usual practice, and they said that they have been practicing for many years and they are okay, so they don't feel the need of changing their practice. So we really need to convince them about what they need to do and why they need to change. Yeah. Next one, please. Right. So with what we have done, so where should we go from now? Yeah. Next one, please. So I just would like to share some tips of successful implementation based on the experience from various hospitals and engagement session. Yeah, we do lots of engagement session with hospitals as well. Yeah, and the staff. Yeah, and one is actually the first and foremost, the leader must support the safe surgery program. Yeah, so that's why when we launched the second edition of the guideline, we actually invited Tan Sri Datuk Sri Dr. Nur Hisham, our DG, to actually deliver the keynote address and launch the program. Yeah, and as a surgeon himself, he's very supportive of that, and even in our meeting, he actually used safe surgery as one of the example of patient safety implementation. Yeah. And all of us need to be a game changer. We need to be in this together, yeah. Regardless whether we are in ministry, in state health department, or in hospital, we have different roles, but we are our aim is just one. We want to improve safe surgery. We want to improve patient safety. We want to decrease mortality and morbidity, yeah, related to surgery. Then we need to train others effectively on safe surgery. We need to explain, like what I mentioned just now, why we need to do this, how to do it, and then we need to cover all staff involved. And we need to do refresher course as well every now and then. And we need the good teamwork as well as communication, and we also need to speak up for patient safety. If something is not right, please speak up. Don't just duduk diam-diam and not saying anything lah. And then if we experience incidents such as wrong surgery, don't hesitate to report. In Ministry of Health, the way we turn the table around is during a hospital directors meeting. For Ministry of Health hospitals, the Director General was there, and I actually announced the hospital that actually report incident most. So we actually turn the table around, saying that if you report incident most, that means you are very much forward in terms of your patient safety, because there are many hospitals who don't like to report any incident. So and after reporting the incident, we must do a proper root cause analysis and improve in terms of the system. And we need to allocate resource to improve the system. Not just training. We need more effective risk reduction strategies like engineering control. And also the use of technology in preventing patient harm. Okay, next one, please. Next one, please. Right, I just would like to share with you the picture when we launched the guideline. So in the middle is Dato Dr. Tan Sri Dr. Nur Hisham, and also on the right is Dato Dr. Anwar Hao, our Safe Surgery Chairman now. Okay, next one, please. And Ministry of Health has taken a few initiatives to make safe surgery a priority. So we started the safe surgery program in 2009. We include safe surgery as part of our patient safety goals. And we also include safe surgery as part of our patient safety course for our house officer. And we also make not just we make near miss also mandatory in our incident reporting, and we make our incident reporting online so people can report much easily. But this one is for MOH. But in the guideline you can actually use, and we actually provide very detailed information on how to prevent patient harm, the risk reduction strategies. I wrote this book myself. So please, you can get all this from the Patient Safety Council Malaysia website for free. Okay, next one. So just as a summary, this is what we have been discussing just now. I would like to highlight this again. Patient harm is a global public health issue, and it can be preventable. So patient safety is essential and requires commitment of all staff, from all levels. And we need to have that safety thinking. We need to have safe practice, safe environment, and safe system. And the evidence have shown that the checklist is effective in improving surgical safety. And in Malaysia, we already have all the governance structure to support the implementation of this program. So I hope all of us can be the leaders in patient safety and safe surgery, and be the game changer in improving patient safety. Okay, with that, okay, this is the committee involved in producing the second edition safe surgery guideline. Next one. Next one, please. Right, this is our Patient Safety Council Malaysia website. You just Google it, and you can find all the circular policy and PowerPoint presentation, and everything is there for you to use, for education and for training. It's available for free. So that's about all, and I hope everyone benefit from my presentation. Thank you so much.
Thank you, Dr. Norasha, for the excellent presentation. Now we come to the Q&A session. Okay. Okay, I think I start the ball rolling. One question to Dato Professor Razman. You know, there is keeping up with a good culture to prevent this incident is important, especially in the era of heightened over of staff in the hospitals. How do you make sure in the hospital to make sure this culture is always there, especially to the new staff coming to your department?
Thank you, Prof. Saleh. I think with regard to the inculcate the culture of incident reporting, I think when we started, I think there always a worriness from the end user, especially the nurses, the doctors, even the junior MOs. They were worried, they're saying that when we request for incident report is more like a intention to investigate and penalizing them. But I think what I had done, I think over the last few years, I think we engaged through the head of department, saying that the importance of this incident report to us, because the only way to improve our quality of care is to know what went wrong. If you keep to yourself, you don't report, we do not know whether you had done wrong. Even a simple incident report like a needle injury, needle prick, sometimes they keep quiet because they worry that if they said that if the needle prick happened, the management will always say they felt that it's their own mistake, but it's not. I think these are the things that how we started, and eventually now it has become a practice. Even a simple example, a delay of a surgery, a delay of surgery, even like example, a case they're supposed to do in a 1 hour example, right? But then it delayed until 4 hours because whatever during the procedure. But we should consider that is an incident report, although that because to us that is beyond the norm of the practice. Then we have to investigate why, and then probably we learn from that. And until now, we have done that as a routine. So now even for the junior one, beside the routine CNE or CME, nursing education or medical education among the young doctors, we always highlight the report. And to me, I think every month what I'll do, I always ask the head of departments, if they don't have incident report, I'll be surprised. There must be incident report at any point of extremes. And that's how you calculate them. But to me, I think when I, in the first few episodes, usually when I come for incident report, I will come for that meeting. As at that time, I was the deputy director. This to show my commitments towards what we are doing, and also to show to the management team and the rest, even for that we meant no harm of looking at the incident. Because what I had experienced personally, if we don't identify these potential issues later, especially when it comes for medical litigation issues, after 2 years, 3 years, you couldn't remember what happened. And then that thing came up and you don't have a data or record what happened. So by having the incident report, at least we had identified the potential issues. So all parties, example from the nursing, from the, let's say if it happened in theater, the surgeons, the anesthetists, even the surgeon, the MOs, the specialists will give a reply and respond. So at least you know what really going to happen. And then probably if there is an issue, at least we can prepare that much earlier. That's how our approach. And until now, Alhamdulillah, it has been such a routine incident for us on reporting. Thank you. Perhaps Aisha can share a bit on your experience because you are more well experienced, especially you're dealing with the bigger hospitals than me.
Right. Thank you, Prof. Saleh, Dato' Razman. Actually, for Ministry of Health, we have evolved in terms of our incident reporting. We started in 1998. So now incident reporting is becoming like a culture already. But our concern now is when we talk about quality kind of exercise, and that includes incident reporting, yeah. So when we talk about quality, it's always about plan, do, check, act. We must complete the loop. So the problem that I can see now in most of our hospitals, they report the incident, they do the root cause analysis, but in terms of the root cause analysis also, sometimes they didn't manage to find the actual root cause. They tend to blame like the patient or certain staff. Yeah, so we really need to train them on how to do root cause analysis properly. And the most important one is the effective risk reduction strategies. Yeah. So this is the one that we try to improve now, and actually without effective risk reduction strategy, incident report just become a pile of reports, and no not much improvement is made. Yeah, so this is the crucial part that we are trying to improve now. Yeah, so not just normally the usual risk reduction strategy is training, but training is not the best. Actually, we need to look into other human other measures that is more effective. So that is what I actually stressed out in my book, the recent guideline on incident reporting 2.0 lah. So it's available in the website. Yeah, so that's one thing. Thank you.
Yeah, the other aspect of the incident reporting probably is learning from the mistake or incident that happened. So by learning from the mistake, actually we can improve a lot from that, inshallah. And this one question, I think it's probably technical question regarding the documentation. Salam, regarding time out before starting surgery, some hospitals are doing it before patient is going anesthesia or intubation, while some hospitals are doing it just before starting skin incision. Should we standardize it? Probably Dr. Narasha can answer that.
I know that, I mean, we have debated on this, whether, you know, we do it before patient is under or after, yeah. But we actually, I mean, consensusly, many feel that we can do it just before skin incision, yeah. But we do know that some people, I mean, do it before patient under, yeah. So maybe Dato also can comment on that. But most hospitals doing it before skin incision.
And I agree with you at a certain extent, but I think a certain hospital I do acknowledge that certain practice differently. But our centers, we prefer everyone to be there before we induce the patients. And I think that's a culture that we have inculcated, so that the anesthetist will not induce the patient as long as the surgeon is not there. So everybody has to be there. The reason being is that sometimes we need to declare in front of patients what are being done, who will be there, and what procedures. The only issues that we found that I think when before inductions because the intention was to inform the patient that everybody is there to start the surgery. We are talking about especially elective surgery. But sometimes we are fully aware, sometimes patient is on sedation. Sometimes they were given the midazolam prior to sending to theatre. So they may be a bit drowsy a bit. But most of the time, usually you will acknowledge the patient, especially to identify their tag, right? Remember that they're dual identifier, either to the hospital, their tag name, and then sometimes we ask the patient their names directly, so that we are fully aware of it. So at the present moment, in my hospital, we are practicing before inductions for the timeout. But I agree with you, Aisha, it's subject for the center, the hospital, respective hospital. But as long as within the checklist, and I think you know that very well, even now, even before the patient going to theaters, there's already a checklist, meaning going to theater at the changing, the transition zones. And then when the NS saw this patient in the reception room, they will also have checked. Actually, it's a multiple level, but we should not miss. But that's subject for discussion. Thank you.
Yes, actually, that's very true. Yeah, because when we look at the checklist, there are multiple checks. If you know, prior to the timeout. Yeah, so actually we should not miss, but we still had incidents whereby, for example, they swapped the patient because the patient didn't turn up. You know, the X patient didn't turn out, so they swapped with Y patient, and somehow that message didn't get across, and nobody really checked the case notes and whatnot. So we did have a wrong surgery even after the implementation of the program. But I think the loopholes that we saw is actually in terms of the true implementation, the checking was not right. You know, everyone was very busy, and everyone just and someone just ticking. Yeah. So in terms of the effectiveness of the implementation and the proper way to implement the checklist, it was not done correctly. Yeah.
The other thing that if I can add in, I think with regards to the surgical performers, yeah, I think at our centers, what we have done is that the responsibility of the patient belong to the team and the surgeons, meaning that I'm, example, if need to operate, I will see the patient pre-operatively, because we know there are certain centers where sometimes the surgeon or maybe a senior medical officer would just look at the list, but they did not see the patient prior. For whatever reason, I'm not going to comment on that, because sometimes the patient may be admitted a day before, was seen by a different doctor. The next day, that doctor was not rostered to do the procedure. It was rostered by someone else, and the patient was not reviewed accordingly. So I think in our practice here, we make sure that, I think in the teaching institutions, because most of the cases are major cases, and I think the cases, if it's to be done by the surgeon or the senior CMO, they have to see the patient prior and do the consultation accordingly. That will protect the risk of being a wrong patient or wrong label. That's one of the initiatives that we do. But sometimes may be difficult in certain centers. But for us, we are in that practice. Thank you.
Is it inside the one of the challenge for Dr. Nasha? All those things. I mean, surgeon who performing surgery should see the patient before the time
Yes.
of surgery.
In Ministry of Health, and also we mentioned also in the guideline that that should be the practice. The one who who will be operating should actually see the patient, yeah, and also check the consent as well. Yeah, we have that issue related to consent very much so as well. Yeah, so that it should be the practice, but sometimes we miss to do that for various reasons.
Okay. From the participant, common mistake occur during shift change, and when there is multiple disciplinary team operation, as there is change in operating team, do you have any good suggestion to reduce this mistake during this time? It's now time to avoid changing scrub nurse during prolonged surgery.
You want me to respond to that?
Maybe Dato, I just respond briefly. The details,
Okay.
maybe Dato can answer. That is the reason why we came up with that multidisciplinary checklist, the one in blue, because these are some of the issues that we experience, yeah, and that actually can lead to error dan sebagainya, yeah. So we really want a complete documentation and want people not to get confused, yeah. Mana satu dia punya team dan sebagainya. So that's why kita come up with that multidisciplinary checklist with the latest edition of safe surgery program lah. Okay, to you, Datuk.
I agree with Dr. Noraisha about that initiative. That's a very good, simple and yet practical initiative that I think you had done. Congratulations. And for me on the ground, because I think I agree with you. Preferably, you don't want to change your team. When I say not changing team, probably the surgical team, the scrub nurses should not change, yeah, because I think they should just continue working until they finish. But somehow or other, especially if you notice, there are cases where the long surgery, onco, maxillofacial surgery, there are sometimes about 8 to 9 hours surgery. We still have that kind of cases. So usually what I would recommend, and then what we are practicing now, if we need to change, the team need to take a break. When I say a break, just about 5 minutes in the theater, especially the scrub nurses when they want to change between the shift. So everybody's break, making sure that the final count of instrument, final count of swab, if there is any pack inside the abdomen, it has to be accounted for, and everybody was very clear about that. Then only we make the changeover, especially if you're dealing with multiple needles. You know, sometimes you do a very small, fine surgery, you can leave out with 20 small needles. Make sure all accounted for and documented is completed before the new team comes in. So the passing over is done not in the harsh manner, meaning that when we struggle, the passing over should not happen because the scrub nurse should focus on the surgery, right? But I think when we settle down and then everybody has sort of a breather, patient is a bit stable, when we say, okay, few minutes for you to pass over, we wait for a while, and then we do accordingly. And so far, I think, alhamdulillah, I think that practice has been settled down. And we were able to reduce the risk of misplaced, miscount, and all those things. But again, as you said, this practice need to be, everyone has to be familiarized with it. Preferably they will stay, the whole team. Tapi you know lah, sometimes because of the long surgery, they have to take a break or even pergi, they want to go for solat or even want to go for toilet kan. The break that has to be formally recorded properly. Yeah, that's my input on the multidisciplinary and then long surgery for requirement for replacement of teams. Thank you. Yeah, timing is important, isn't it? Yeah, timing is important. Don't leave the surgery when there is a situation of havoc or something like that. Yeah. So cool down everything.
Another thing that Prof. Saleh, maybe if I can highlight, is actually about the harmony environment or in the OT, yeah, because we had cases whereby the nurse actually counted the swab and it was not tally, but she was very afraid to tell the surgeon what's happening. So at the end, they just close everything without knowing that maybe the swab is inside. Yeah. So this is, I think, something that need to be highlighted, and the harmony, working harmony in the OT, I think that's very, very essential. Otherwise, people don't want to speak up. They are so afraid. Yeah. And at the end, we will ended up with unintended retained foreign body, at the end of the surgery. Maybe Datuk can comment also on that. Over to you, Datuk.
I agree with you, Aisha, with this manner, because I think that communication is very important. I do communicate with everyone, even my anesthesia, because I think it's very important, because you cannot just simply confine to the surgeries. Example, when I'm in trouble, where I think if I may have nick or causing bleeding a bit, right? I will have tell them that I'm anticipate bleeding, please get ready. Because sometimes if they don't inform, they'll think everything is okay, but at least they're prepared. This is even for the nurses. But I believe nowadays, most of our surgeons are nice, like Prof. Saleh. Nowadays, I think you all, I think I know Aisha had experienced previous surgeons, but I think that's why I think part of the training that we have to tell our trainees that I think you must, in order for you to gain respect, is not to shout at people unnecessarily. For you to gain respect is for you to behave as a gentleman and then behave professionally. And if people will accept you in a different ways. And I think everybody make mistake, we agree, but I think you should not blame them for doing that. So that's why I think the learning process has to be there. And I believe nowadays the environment are much better, but inshallah I think the staff should be able to communicate very well. This is my opinion about the present surgical practice in the country.
Yes, I think there are a lot of changes now to the surgical fraternity. I think surgery is now more mellow down, isn't it, Professor?
It's not mellow down. We are still strict. We are still disciplined. But probably the communication skill are much better. Okay.
Okay, inshallah. I got one question to Dr. Raisha. You presented in your presentation just now after 10 years of implementation of this initiative, I think there are still incident that fact left behind, all those things. What do you think the obstacle and hindrance of this implementation? Why this thing still occur?
I think it's about the use of the checklist effectively. That's one. Yeah. Sometimes people still just do it as a routine and just tick. Yeah. So it's a ticking box exercise. So I think that's one. And number two is about not being able to speak up. Yeah. So if some people some staff are still a little bit scared to speak up, and if they are worried about something, yeah, so that we should actually enhance and at all levels, including the paramedics, to be as part of the team. Yeah, so even if you are new, you need to actually speak up. And also another thing, sometimes because of the turnover of the staff, yeah, sometimes we don't really properly manage to train our staff properly, yeah, and also the turn in terms of the load or the load of the work, yeah, so many cases, so people just want to do things very fast, yeah, and that is also one of the factors that contribute to us making error, because we don't check properly. Yeah. So I will share all these in my next presentation next week. Yeah, on the cases. Yeah, why we actually had wrong surgery happen. Yeah, unintended retained foreign body.
Yeah, probably that institution had to do awareness program periodically to the hospital, and to make sure everybody knows all these things. And the other thing is to enhance the communication. I think this thing should be tackled properly as well. Anything in HCTM in terms of periodic awareness to the hospital done?
I think with regard to those activities, I think we do have through our Jawatan Kawasan Dewan Bedah, we are looking about those things, especially trainings for the new medical officers and also for the new nurses. And also sometimes I think what we have do based on any untoward incidents reports here, that's why sometimes part of the remedial we will encourage of all this practice that retrain basically of our staff and everything. One classic example, last time we used to have one case where I think the medical instruments was an issue, because I think there's an energy device instruments, right? So although that did not cause a major issue to the patient, but I think we found that there is some issues. That's why I think what we have done, we collaborate with the industry, we call them to give a proper training to our staff and everything. The reason being is that the only mistake was, example, that instrument are supposed to be single use, but being a cheap hospital, sometimes it will recycle, and that's where it create unnecessary complications. So I think that's why I think it's very important to get this learning process from all together, especially from the industries, because I think new technologies comes in, and I think that's we have to be aware of it, and then we have to update ourselves on all these new technologies, making sure that there is no potential risk or complications that happen during these things. And that is our strategy, because I think, I don't know why, I think a lot of hospital industry like to come to us and promoting their product. I guess probably because we are teaching centers. So they felt that it's easier to be introduced to our centers for this kind of instruments or any new devices.
There's one question here from the participant. Doctor, what hinders staff from reporting incident and mistake in SSSL is the environment during root cause analysis. Is there anything to improve this situation and make it more towards learning from mistake rather than blaming patient? Sorry, Dr. Narasha, I can answer.
Right. Okay. I think when we talk about reporting, the leader first of all should promote that this is important, incident reporting is important, and it is not going to be a punishment for you following that report. Yeah, so it's all about improving the whole system, the system in the healthcare system, not about punishing the individual involved. Yeah, and I think if that is the spirit, we can actually encourage people to report more. And another thing is Ministry of Health, for example, I have transformed our incident reporting system from a very lengthy report to just a very simple, quick reporting, so that we can get the essential information and the details we can get from the root cause analysis report. Yeah, so we must make it easy, and we must actually encourage our staff to report. And reporting is not about punishing or blame culture. It's about improving the whole system. And I think if that is the spirit, we can definitely improve on that. Thank you.
Okay, is that okay? And there's another question. After long duration of using this form for SSL, is there any changes needed, or it has been completely assessed, or probably they're looking for a new set of form? Probably, I'm not sure.
I think we just revised our guideline and our forms in 2019. Yeah, so it's still quite new. Yeah, so and we have included a lot more element into that based on the feedback from the implementers. Yeah, so we are going to get feedback from the implementers, and maybe after a while we're going to see whether we need to do some improvement. Yeah, but 2 years is still very new. But again, I know that some hospital, they actually amended some parts of the checklist. They add a little bit more just because they feel that, okay, they want to know a little bit more. They want to make sure this is done. Yeah, so they do add on certain information or elements in the checklist. Yeah, that one we actually leave it to the hospital. Thank you.
Okay, thanks, Dr. Norisha. One more question. How do you ensure confidentiality of these report incidents?
Good question. Can I answer that?
Yes.
I think I know Prof. Nasir asked a question. Difficult question, Prof. I think any incident report will ensure a strict confidentiality on who's managing it, because we don't want to I would say undermine anyone. And I think that as we discussed for the last 2 hours, the intention of this incident report are not to penalize anyone, just to identify what are the weakness areas that we need to improve if there is any, and what are the mitigation plan that we need to do if that incident is something that need to be sought out. So for me, I took it very confidential, and even those who are handling the report are very reliable within the administrative capacity. And we only call certain individual if it's related with, I think, a decision has been made by the committee. If the committee feel that is something that whoever had something happen, and then you need to call certain individual to get advice, then they will making sure that there's very senior people who will advise that person for any mishap, with intention to improve the outcome, not to say that, not to penalize them. So we take it very professional, very, and then we don't use this to, I would say, we don't use this to intend to discriminate them, even on their performance, because this, I would say, if we treat this confidential report as a professionals, I'm sure those who accepted the outcome will take it as a professional as well. That's my opinion about the confidentiality of any reports.
Right. Maybe I can add on to that. in our experience in Ministry of Health hospitals, last time our system basically has to go through, if you want to report an incident, for example, it happens in orthopedic department, the person involved will, fill in the form and then had to submit to the supervisor and then to the head of department and then to the head of the quality unit and blah, 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 blah. So, and sometimes what happened was the superior at the department actually stopped the reporting. Yeah, so meaning although the staff actually report, but the superior, yeah, maybe the supervisor or the matrons or the doctors, the head of department actually refuse to submit it to the quality department of the hospital. So to prevent that from happening, we actually had bypassed all, yeah, and basically if you report, if someone, a staff report an incident, it will go directly to the quality unit under the hospital director office. Yeah, so that is actually one of the ways to ensure also confidentiality and to ensure that the report is not being, someone actually stopped the report from being analyzed and doing root cause analysis. And I think in terms of confidentiality, normally the people involved in investigation and stuff, they can ensure the confidentiality, but sometimes when the incident happened at the ward, for example, or in the surgery, the word of mouth of people involved in that incident, actually they are the one who actually spread all the information and membawang and everything. So at the end, everybody knows about it. So that's, I think, the challenge lah, just to, it's not that difficult, it's not that easy to make sure people just keep quiet after an incident. But the process, most of the staff ensure that confidentiality, but it's just the people around, when the incident happened. Thank you.
Yeah, the other thing that I was involved in the incident reporting committee in the HTA before. Actually, in the report, actually the name of those involved is not stated in the report. Just put it something like A, B, something like who's involved in the program, in the incident. That's the way, one of the way to keep confidentiality. Okay, that's another question. Of all the challenges faced in the effort to implement optimum SSSL, which challenges poses the most difficult among all? Probably you can start first, Dr. Narsha, after that, Prof. Osman.
I think actually the for the paramedics is much easier to convince them, but it's not easy to convince the surgeons actually. But that's my personal experience. Yeah, so actually, for me, the surgeon themselves need to be the champion and actually promote the safe surgery themselves. Yeah, if someone else promote the safe surgery to surgeons, it's not that easy. So I think surgeons themselves should be the one who need to disseminate the information and sell safe surgery to other surgeons. Yeah, but from my experience, the nurses, the anesthesiologists, they are much easier in terms of their the way they want to receive the safe surgery program. I'm sorry. I hope I didn't hurt the feeling of the surgeons.
You can have
I have to accept that. I have to accept it with open heart, Aisha. And actually, I think I agree with you at a certain extent. I think when dealing with the implementation of this optimum SSL, because I was involved directly when I was the head of Department of Surgery in 2011, and then eventually become a Deputy Director of Surgical Services. And I think I agree with you at a certain extent. The senior people are the one that are a bit difficult to make the changes, because I think, again, a culture. There's nothing wrong with it. I think it's just a matter of culture, because to me, I think they felt that they have done whatever they have done for the last 10 years, 20 years. They said, is their culture, which they think quite safe to their patient. Although it's slightly beyond outside the norm of the standard as safe surgery, safe life. But I think it's just a matter that we just have to be very persistent, and I think we make the changes accordingly. Sometimes that what I did eventually when this come effort, I insisted on the operating theaters. If that particular surgeon don't come, either you don't do the case or you send back the case. Let him explain to the patients about that. So we mean business. I think to me as a I would say in the management, it's when you delay 1 hour, you're wasting one case to be done. So if they couldn't come on time, then it's not fair for the other patient that has to be postponed, as other examples, right? So I think over time things have changed. Alhamdulillah, they are more tolerable, and then they are happy to accommodate that and a certain extent. So now I think if you ask me over the last 10 years, things are much better. Now, I'm sure you won't agree with me. Things are slightly better compared to when you started last time.
Yeah. We are in Ministry of Health. We are very lucky because we do have surgeons who actually champion safe surgery. You know, neurosurgeon, orthopedic surgeon, and general surgeons, ophthalmology. So we actually include various disciplines, and they actually the one who actually promote safe surgery, and I think that's the way to go.
Agree.
Yeah, that's right actually. Thank you. Okay, since there is no other question, I think Alhamdulillah now that we have reached the end of this Q&A session. I would like to thank Dr. Noraisha and Prof. Dr. Razman
Thank you
for their great sharing with us. Jazakallah khairan katsira. And it has been very informative and very interesting. May we strive our best to apply the knowledge that we have gained from this speech. I would like to apologize for any deficiency during this program, this session. Thank you again. And now I return the mic to Mr. Chairperson.
Sorry, Prof. Saleh, I just would like to share one more information. We are celebrating the 3rd World Patient Safety Day on the 17th of September this year. Yeah, so we actually have a free webinar that everyone can join. Yeah, just visit Patient Safety Council Malaysia website, and all the information is there. Yeah.
Okay,
so we will have the Director General of Health himself delivering the keynote address. Thank you.
Okay, welcome.
Thank you very much for the very intense discussion. Ladies and gentlemen, it seems we have reached the end of today's session. But before that, allow us to savor this moment in the form of a picture. We would like to request all participants to switch on their camera for a screenshot. There's quite a number of people who has not yet switched on their webcam. Again, if you would be so kind, we would like to request all participants to switch on their camera for a screenshot. I thank you very much for your active participation in this symposium. I hope that everyone enjoyed the program. Join us for the second part of the symposium. On next Monday at 2 p.m. We'll be looking into details such as common issues in SSSL, the standard operating procedures, leadership as well as etiquette in the operating theatre. A friendly remark, don't forget to claim your CPD point from the registration link provided in the chat box. An e-certificate will be rewarded by the end of the symposium based on the sessions attended. Pardon us again for any glitches. All good deeds came from Allah and the bad resulted from our weakness. With that, I thank you and I thank all the key speakers as well as the moderator, and see you again next week, inshallah.
Thanks, everybody. Okay. Okay, alhamdulillah. Recorded.
Ada lagu tak?
Ya.
Alhamdulillah.
Saya tak dengar, memang tak dengar.
Hah?
Okay.
Oh, rotation.
Dengar gitu Ikhwan.
Abang Nasib pun tadi pun saya tak tahu itu apa, sebab mungkin dia tak dengar. So. Thanks very much.
Tak silent Ikhwan, dengar apa yang korang borak.
Baru sampai.